Good morning, everybody. Now you can relax a little bit. These cases were excellent, very, very tough. I was very hard thinking about these brain injuries because it's not my speciality. So, now we moved to trauma cases, and I guess you probably see a lot of trauma cases in your institution as well. Let's see what you will get in this lecture. Now, looking at the trauma incidents, who is involved in facial trauma, then you can look at these numbers, and these numbers, they come from our institution. I live in Innsbruck. It's also in Austria. It's in the western part of Austria. It's about 2 hours by train from a beautiful Salzburg, and I live in a mountain area. And you can imagine that people, if they don't work, they go up the mountain, and fortunately they will have to go down again, and a lot of things happen. We also have traffic accidents. We do not have so many violence, so that's also an important issue in facial trauma, considering what can happen late in the evening with testosterone filled drunken men, but that's leading us to the incidents. And look here, most people affected by facial trauma are in the younger age range. The most frequent population is aged less than 30 years, and we have this range of let's say between 15 and 55. So these are the population we need to deal with, and that's a lot of young people, and considering radiation dose, this is also an issue, but we have another lecture for this. And now, what's the reason for facial injury? It's usually traffic, motor vehicle accident, and sports. It's also followed then by violence. Work can also be a factor for the reason for facial trauma. And looking at the typical kind of injury, then we have lay 4. Lay 4 is something we learn, but it's not the majority of facial fractures are lay 4 fractures. They account for roughly about 5% of all facial trauma. More frequently involved is the zygomatic fractures, followed by about 30%, and orbital floor, involving the orbit. The maxilla is around roughly about 10%. The mandible fractures are about 20 to 25%, and nasal bone. We do a lot of imaging just for ruling out of a nasal fracture. It's not so frequent as you may guess. It's roughly about 7%. Now, in children, facial trauma also occurs quite logically, but there's a different age range, and the different causes depending on the age. If we look at the young children up to the age of 7 years, then it's predominantly motor vehicle collision and fall from running around the floor. Child falls down and typically falls at the nose and at the face. Now, if children grow older, up to the age of 13, when they enter school, then there's an increasingly cause of facial trauma related to sports activities, because they enter school, they do some sports, they ball sports, all like that. So it's about 25% is sport the reason for facial trauma. And if children then enter the adolescent age, then assault and battery increases. So that's probably something human. They start fighting, and it's about 24% a cause of a facial trauma. The predominant fracture site is the maxilla and is the nasal bone. That is caused due to the physiognomy of children. They have depending or in relation to the body size, a very large head, and if they fell, then they fell, of course, predominantly to the face, to the nose, to the maxilla. There are additional classifications. Leaf-4 is very, very rare in children. Orbital fractures, they are also quite high. Consider, a ball falling into the face. In elderly patients, these are patients aged above 65 years and older. They have different etiologies and reasons for facial trauma, and the most frequent is falling from standing. Old people, they get less flexible, they have less control of their movements, and they can fall, and you probably know these situations. It's not only the hip where they fell, they can also fall on the head and on the face. And what is very common now in our population in Austria, old people, they are very healthy and fit, and they buy an e-bike, and they go up the hills, but of course they need to get down, and they have problems with braking, and they fell, and they also fell on their face. So bicycle accident is a very increasingly reason for facial trauma in this population. Again, what is the frequency of certain type of fractures? It's zygomatic complex in the elderly people, roughly about 1/3. Orbit, 1/5, and Leaf-4 fractures really not so frequent as one may assume when dealing with fractures of the face. What can we do if a patient has a facial trauma? We need to decide the cause and the severity of the trauma. In heavily injured patients, you need to bring patients in the shock room algorithms because they have a high accident, a high velocity accident involving the face, involving probably the skull, involving probably other parts of the body, and these patients, they have to follow an algorithm, what we call a shock room algorithm. It's here listed in one of our early publications when introducing such a shock room algorithm in the University Hospital in Innsbruck. And it always starts with a first emergency room phase. The patients usually are brought there to the emergency department, either via the ambulance or via a helicopter, and then the patients will be brought down to the shock room, and the leading anesthetist will look and evaluate the patients at first glance. They do, the stabilizations, the immediate measures. They look what's happening with this patient. Is this patient hemodynamically stable? And if they manage to have the patient stable, then these patients will enter our CT facility, and then we have a certain algorithm of scanning procedure. It always starts, and I'm quite sure that it works very similar in your facilities too. We start with a CT, a native CT without contrast of the skull, because you want to see the bleeding, and is there any brain fracture? Then this is followed by a CT angiography of the head and neck area to rule out any vascular injury that could happen, and to rule out any traumatic injury to the cervical spine. And then we have a cost-enhanced CT scan of the thorax and the abdomen to rule out any other relevant damage to the other body parts. And then we decide, of course, what to do with these patients. Is there an urgent surgery needed? Can some fractures be operated, or have they to be operated very soon, or is there too much swelling, or can they go directly to the intensive care unit, or in case of an acute bleeding, can we do it interventionally by embolization? And so this is what the patient usually will have in cases of a severely trauma. And this is an example of a patient who is involved in a in an accident after ski trauma. The patient smashed into a tree, and see, this is really what you don't want to see in these patients, the bleeding here in the ventricles, also here. In the fourth ventricles, you have some edema, you have some microbleeds. You may suggest, this smashed face, and this is the reason why I show you this case, because you see, these multiple fractures of the face, and we will systematically go through these kind of fractures, but don't worry about a smashed face. People don't die about this due to the smashed face, but they die because of the injury in the brain. So this is very, very important information. And also look at the spine. You see, this is the same patient. Yeah, he has fracture, of the second vertebral, the axis. And this is a real big problem for this patient. If you have an isolated facial trauma, so you don't assume any injury to the brain, then you can go for a completely different protocol. You don't need high dose because you do not need to see the brain. You just want to look at the bones, and to see fractures in the bones, a CT dose index volume roughly about 3 milligray is really sufficient to diagnose fractures in the bone. And you see this example here. You see very nicely the fracture of the lateral maxillar wall. You see the orbital floor fracture on this case. And if you reconstruct images also in soft kernel, and this is an important information, you should always do it in facial trauma, then you will never miss any dehiscency or entrapment of muscles and of fat here. And this can be done with very, very, very low dose. Okay, now going back to anatomy, the bony components of the face. So they consist of the frontal bone, the nasal bone, the maxillar bone, and have a look. This process, the frontal process of the maxillary bone. This is the maxilla. This is not the nasal bone. Yeah? This belongs to the maxilla and also the apertura. This is part of the maxilla. It's not the nasal bone. So a nasal fracture may roughly also involve the maxillary bone. Then we have the zygoma, the zygomatic bone. This is a very important structure. We will go into detail then in a couple of next slides. And between these bony structures we have sutura, and they are called frontonasal sutura. Then it's the frontomaxillary sutura. So in this part it goes from up to down. Then we have a frontozygomatic sutura. Then we have the zygomatic or maxillary sutura, the temporozygomatic sutura, and the nasomaxillary sutura. So to remember the name, the first name, it goes from the vertex down to the mandible, and usually from back to anterior side, but not for the nasomaxillary suture. This is first nasal and then maxillary suture. So you may more easily remember these sutures if they are ruptured due to a fracture. The orbit, the anatomy, we have the orbital roof. It is composed of the frontal bone on the anterior parts, and on the posterior parts, the sphenoid bone. The medial wall is comprised of the maxillary bone here, the lacrimal bone, the ethmoid bone, and on the very, very back, the sphenoid bone. The orbital floor is continuing from the maxillary bone here, going back to the zygomatic bone, and there you have the also maxillary and palatinum here on the as basic parts of the orbital floor. And to complete the anatomy, On the lateral wall, we have the zygomatic bone here, and the sphenoid bone, a large part consisting or building the lateral orbital wall. So a lot of parts of bone circumferencing the orbit. When we have a trauma or a force hitting into the face, then this force is transmitted to the other parts of the bone, and this is called the facial buttresses. And they're vertical buttresses. You see the in orange, the vertical buttress is the nasomaxillary buttress, the zygomaticomaxillary buttress, the pterygomaxillary buttress, and there's a very small maxillary, pterygomaxillary buttress, and we have horizontal buttresses. That's the frontal bar, the infraorbital rim and nasal bones, and the hard palate and maxillary alveolus. So forces, they are following, of course, these buttresses, and they fracture always at the weakest part of the facial buttress. And this is usually here where the zygomatic bone enters in the other parts of the bone. This is an area here in the maxillary side, also here between the frontal nasal sutura. There is a very frequent, predominant weakness where we have fractures very frequently. Now look at this case. It's a ski accident of a 62-year-old woman. And yeah, what to do with this case, how to describe it. Is it some kind of Lefort fracture? Is it just an orbital complex fracture of the orbital floor, or zygoma and maxillary multi-fractured case? How do you want to call it? Yeah, look at these images, and with the next slides, I will show you how to correctly describe this case step by step, and to make it more easier for you to deal also with these complicated cases, instead of just saying, yeah, this is a complicated maxillary or midface fracture. You're referring, maxillofacial surgeon would not be happy with you if you describe every fracture part. Yeah, there's a small fracture part, yeah, infraorbital, then they're very close to the maxilla, next part, and next part. It's useless. But let's see what the fracture types are. Now, I want to start with the classic Lefort fractures. You certainly have learned it in anatomy course and the trauma course. You see this line, this is Lefort 1 line. It's a complete fracture of the maxilla, so a separation of the entire maxilla from the midface. That would be Lefort 1. Lefort 2 includes also the nasal component, and it runs to the anterior part of the maxillary sinus and the orbital, the orbit, and this is a separation of the nasomaxillary part of the face from the skull. And in Lefort 3, you really have the separation of the entire facial bone components from the rest of the skull. What is an important criteria for Lefort 1? If you're going through the axial CT slices, then it is really important that you look here at the pterygoid process. So the fracture has to run through the pterygoid process, and if it's not the case, then it could be a fracture, of course, of the maxillary sinus, but it's not a Lefort 1 fracture. It needs really running through the entire maxilla, and this involves the pterygoid process. This is very important information you should report. In Lefort 2, the fracture includes the anterior and the posterior wall of the maxillary sinus. You see here a case where it's happening on both sides, classically. And in Lefort 3, there's a nasal bridge involved. You see also involvement of the medial and the lateral orbital wall. Look here, and the zygomatic arch. And it can be that it's not completely symmetrically in both sides. It could be that on one side it's classic, and then the other side maybe the zygoma is still intact, or it's not fracturing the lateral orbital wall. So this can also be not completely symmetrically, can also be asymmetrically. But these are only 4 fractures. Now, going to the next complex, and we will discuss the facial anatomy now in complexes, and this is the reason because it's a very important for surgical repair, and you see it on the subsequent slides why this is so. It's the nasoseptal complex, is the next very important complex, and looking at the anatomy, we have the nasal bone, we have the maxilla. So this is maxilla, that's not nasal bone, and we have the septum. And the septum is composed of a cartilage part and of a bony part. The bony part here is the vomer. We have the perpendicular plate of the ethmoid, and we have the cartilage part, the large septal cartilage, the anterior nasal spine, which is a very important information because it's the attachment of the septum to the bone. And then, of course, we have the upper lateral cartilage and the lower lateral cartilage. They can also be fractured, but the most important structures are bone and the nasal septum. Looking at this case, what can you see? And the arrows already indicate what's happening here. You have a fracture of the left side, a fracture of the right side, and you also have a fracture of the septum. There are some classifications, and I think you don't need to know these classifications, but just to show you how it can be classified. And the major classification includes a lateral oblique force or fracture pattern and a clear frontal pattern. And in this case, we have a displacement of both frontal processes. So this would be classified in this case as a grade 3 according to strength classification, and the frontal fractures, grade 1 is just the cartilaginous septum, then flattening of the bony pyramid, and a grade 3 is a deformed and shortened nasal septum. What I want to show you in these images that please look carefully at the nasal septum, because the septum is a very important structure. You see it in the coronal reconstruction. The septum is separated here, and you see this kind of right side movement. You see this step here. The nasal septum is an important structure because if it's not fixed, then you have a movement between the patients really have difficulties in getting air through the nose. So this is an important structure that needs to be fixed if there's a significant fracture of the nasal septum. The next complex is the naso-orbito-ethmoidal complex, and you see it in yellow. This is the naso-orbito-ethmoidal complex, and it comprises of the nasal bone, the medial orbital wall, and the frontal maxillary process. And here you see the critical structures. And this is the ethmoid infundibulum. Here you have the nasal lacrimal ductus. It's here, and the ligamentum palpebromediale is here. It's not really a bony structure, but it's a ligamental structure, but we will see why this is an important structure. And what's happening if you have a fracture involving the ethmoid infundibulum, you may have, as a consequence of this trauma, a mucocele or a chronic sinusitis, because if the infundibulum is narrowed or occluded, then mucus cannot drain into the natural orifice, and it will form a mucocele. If the ductus nasolacrimalis is involved, then the lacrimal fluid cannot flow into the nose. So you have a lacrimal fluid obstruction. Lacrimal fluid will always drain outside the eye, and this is a very bad condition for patients. And if the ligamentum palpebromediale is fractured, then you have an impeded eyelid fixation, which is not very, it's also a very uncomfortable condition for patients and needs to be surgically corrected. Here you see a case where you have an involvement of the naso-orbito-ethmoidal complex with a large central fragment. You see, this is the large fragment of the naso-orbito-ethmoidal complex. You see the fracture here on the medial orbital wall. You see the emphysema here, and this is an important structure. Then you see this large fragment. And in this schematic drawing, you see we have this situation, a large central fragment. This is the ligamentum palpebromediale, and if this is ruptured like here, then the eyelid is not fixed anymore, and this is a case, this really needs surgical correction. Next is the orbital complex. It's a very frequent complex. Remember on the first, in the introduction on incidences, there we have a special fracture. It's called the trapdoor fracture, and it might, if you have a very short glimpse at this image, it might look quite well. Maybe this is some sort of a retention cyst or mucous swelling, but in fact it's not. You see trapped orbital fat and trapped orbital muscle. The rectus inferior muscle is really went into the maxillary sinus, and the bone is trapped back, the fracture, and it's fixed in space, and this of course needs surgical repair. These patients will certainly have double images and motility restrictions, so the eye cannot move accordingly. Next, the classic blowout fracture can be on the orbital floor, as seen here. You see the displacement of the inferior orbital wall, very deep, the hystency, and can also involve the medial orbital wall. They can also be isolated, either just medial or the orbital floor. And of course, the consequences could be an anaphthalmos, double images, and you see also emphysema. So here, intraconal air related to trauma. Now, the zygomatico-maxillary complex, consider elderly patients, very, very frequent. It depends on how severe is the displacement of the zygoma, and according to Singh, they can be classified as just an isolated incomplete fracture. This is the most frequent, but it can also, as in this case, a zygomatic avulsion, and going further, if there's a fragment, also a fragmentation of the zygoma, then it's really a crushed zygoma, and this of course needs to be repaired. And the most important complication is a limited mouth opening, because due to the muscles, this part of the zygoma will be pushed medially, and you cannot correctly open the mouth anymore if you have this fracture. The dentoalveolar complex is especially in younger patients frequently involved. It's a fracture of the teeth and the alveolar complex, and please always look at the teeth. Is there a luxation? Watch carefully also the sagittal reconstructions, the coronal reconstruction. You see fracture running through the alveolar process, a transalveolar fracture, and this has to be reported because these patients need to be treated by the craniomaxillofacial surgeons. Now, what's this? Of course, it's a complex mid-face fractures, and we can report all these complexes we just heard before. It's a zygomatico-maxillary complex fracture. Here you see that this is the zygomatic bone, and it's completely displaced, so this is fractured. Next, the orbital complex on the right side, orbital floor, or left side, right side, running through the maxilla here, orbital floor, and therefore it's an orbital complex fracture. Then the dentoalveolar complex is fractured here. Fracture runs through the process. It's a nasoseptal complex fracture. Look here. nasoseptal complex is fractured. And we have a naso-orbital ethmoidal complex. Looking here, it's a 3D reconstruction. You should read images, of course, in axial, coronal, and sagittal images, but this is just for demonstration purpose. And this is the reason why we learn all about these complexes, because this is the surgically important unit, and we go through it. You see, the zygomatico-maxillary complex is fixed via these microplates. Yeah? It's fixed in place. Then the orbital complex is fixed. Use the metal mesh here. The orbital rim is fixed. Inferior orbital wall is fixed. Then the dento-alveolar complex. Yes, look here. Yeah, it's fixed by this interdental fixation, and also by these mini screws. The nasoseptal complex is fixed, yeah, running here. And the naso-orbital ethmoid complex, you see the microplates here, that's needed to fix this fracture, to have stability on the medial part of the eye. Now going to the mandibular. Mandibular is composed, and I'm just looking at the time, I hope I do not run out of time now, I think it's quite okay. It's composed of the symphysis, here at the center, until to the canine, then the body, the angel and ramus, the coronet, and the condylar process, and the head. So we have transition zones that separate in the symphysis from body. It's the anterior transition zone 1, and we have a second, and it's called naturally the posterior transition zone. The mandibular. Going to the back side, what is the head, what is the neck, yeah, where's the border between neck and base. Then we have these helpful lines. The first line is the condylar head reference line, and this is the tangent line caudal to a sphere, and this is a sphere. You have to imagine this sphere if you read the images. Around the lateral pole zone, and this separates the condylar head, this is the condylar head, from the condylar neck. This is the condylar neck. Next line is the sigmoid notch line. Here you see the sigmoid notch, and this line runs through the deepest point of the sigmoid notch. This separates, of course, the condylar neck from the condylar base. And where is the condylar base? It's defined by the mesenteric notch line. And this is 1/3 of the distance from the most prominent point of the posterior border of the mesenteric tuberosity to the sigmoid notch. Yeah? And this is where the base begins. And this would be the angle of the mandible. If we have fractures of the condylar head, then we have these 3 subtypes. The first is called M fracture. The fracture line courses medial to the pole, and please consider this as a circle at the lateral posterior border. So if the fracture is medially, then it's an M fracture. A P fracture if it's running within the pole, and a P fracture with fragmentation is a combination of both fractures. Now let's have a look at a case. You see a mandibular fracture. You see the fracture of the left body. Look also at the teeth. Yeah, avulsion of tooth 33. Yeah, you see it on these coronal reconstructions. But you also have a fracture of the right head. Looking here, the right head, and a fracture of the left head. So if people falling on the chin, so please carefully read also, you know, the condyle and the head, neck of the mandible. Now the last thing I want to discuss with you is neck trauma. It means trauma to the neck. It could be a cervicovascular injury. It's grade 1. It's an intimal injury with irregularities of the intima, which are not atherosclerotic findings. Then grade 2 is dissection. That's a very dangerous thing. A pseudoaneurysmal formation, and vessel occlusion or thrombosis. Why is dissection a problem? Do you know it? Why could dissection be a problem? Yeah. Yes, it can go intracranial, you're very right. And what else could happen? Yes, of course. Yeah, great, excellent. Vessel transection, of course, it would be transected. Okay, so when can we consider cervicovascular injury in neck trauma? If we have fractures that enter the transverse foramen, or the fractures are very close to the vertebral arteries, and also in fractures of the C1 ring and the C2 vertebral body. So please look very carefully at these vessels, and that's the reason why we have a CT angiography of the head and neck area in these kind of trauma scenarios. This is an example of a dissection with occlusion of the right vertebral artery. Look at the reconstruction. There's no right vertebral artery. On the left side, you see the vertebral artery. You cannot see it here. Look, have a look here. Have a look here. But it can be contralaterally filled from the other side of the collateral circulation. So you really have to look at every part of the neck. Just don't look intracranially and see everything is fine. This could be really misleading because you may miss this posterior ischemia due to thrombus formation on the dissection flap, and it could run up and may cause a posterior ischemia. So this is a very bad complication, and if this is not reported, then you will have a problem because some months later this will bring you to very uncomfortable explanations for legal court affairs. We also can have trauma to the laryngotracheal components with blunt or penetrating trauma, damage directly to the larynx, also hanging and strangulation. I'm sure you have seen some cases with hanging, and then you have to check whether the vessels are okay or if the components of the larynx are not fractured. Cut, of course. What do you see? And it's a typical image of a hematoma and a large hematoma here in the larynx. You see the swelling, and this can cause, of course, problems with breathing. They have severe problems in breathing, these patients. Next, if you have an emphysema, this is a very important information. If there is some air outside the larynx, then this should not be the case. There must something happen. Even there's a rupture of a small laryngocele or the ventricle. If you see air, then you have certainly a trauma to the larynx, and also fractures. And how can you evaluate fractures? Please reconstruct these images in every case of a trauma to the neck using bone kernels. Maybe your radiation technicians, they don't do it automatically, but then if you have a trauma there, tell them please reconstruct these images in very small slide thickness and use hard kernel reconstructions to involve damage and fracture to the laryngeal bones and cartilage. So summing up this lecture, facial trauma, young adults are most frequently involved in this kind of trauma. Do not just list any bone that is involved because our surgeons will not be happy. They have, of course, to read the images by themselves, and they will do it, but focus on the critical structures that are affected because they may lead to possible complications, and I've shown you some images and explanations why this could be, especially the drainage for the mucocele formation, and the eye problems, of course. Then describe relevant clinical functional anatomic complexes. I hope I could make it clear because these are the complexes that the craniomaxillar surgeons need to repair afterwards. And for the neck trauma, be aware of blunt vascular trauma and be aware of the risk of ischemia if you have a dissection or if you have an occlusion. And just don't look at the intracranial vessels because there's a collateralization from the other side. Really look carefully at every part of the vertebral arteries to really be sure not to miss any vascular injury, use the additional hot canal reconstruction for laryngeal trauma, because otherwise you cannot see tiny fractures. And